Hello and welcome to a presentation on generalized anxiety disorder. Today I will describe the symptoms, etiology, assessment, treatment and outcome measurement associated with generalized anxiety disorder. The DSM-5 criteria outlines the central feature of generalized anxiety disorder, or GAD, as excessive anxiety and worry, anxious apprehension occurring more days than not for at least 6 months about a number of events or activities. Furthermore, the individual finds it difficult to control the worry. This is accompanied by at least 3 of the 6 following associated symptoms: restlessness, fatigability, concentration difficulties, irritability, muscle tension, and sleep disturbance. The DSM-5 criteria for diagnosis of GAD notes that a clinician must rule out symptoms that occur exclusively during another mental disorder, i.e. mood disorder, a psychotic disorder, post-traumatic stress disorder, or panic disorder. Furthermore, symptoms cannot be due to physiological effects of a substance or due to a medical condition. Finally, the anxiety, worry, or physical symptoms must cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. To break down GAD further, I will address what is anxiety. Anxiety is a feeling, a physical experience in the body. We get anxious bodily before we know it consciously. Like the other anxiety disorders, GAD is characterized by a process called anxious apprehension. This involves a future-focused state in which the person anticipates and proposes for upcoming negative events. This mood state is accompanied by an attentional focus on threat-related stimuli, high negative affect, and chronic tension and overall arousal. Anxiety is centered around our fight and flight response that is controlled by our amygdala. GAD sufferers find the world as a threatening place. Being continually stuck in the fight and flight response triggers our somatic nervous system, our sympathetic nervous system, and our parasympathetic nervous system. The somatic nervous system is affected by anxiety when the client exhibits stiff neck, clenched hands, tense arms, feet, and legs. The sympathetic nervous system reacts with elevated heart rate, rapid respiration, dry eyes, dry mouth, dilated pupils, and cold hands. And finally, the parasympathetic symptoms, which indicate heightened anxiety that is not well regulated by the client. These include salivation, warm hands, runny eyes, low heart rate, nausea, vomiting and diarrhea, low respiration rate, dizziness, foggy thinking, and ringing in the ears. It is important to note that when anxiety is discharged into the parasympathetic nervous system, the hippocampus shuts down, so the patient is unable to think clearly. Etiology refers to the cause of the disorder, and in GAD there are 3 identified causes: genetics, brain chemistry, and environmental factors. GAD is a moderately heritable disorder. Genetics have been found to increase the likelihood of a GAD diagnosis through a generalized biological vulnerability for anxiety. A parental history of GAD, major depressive disorder, panic disorder, and substance use disorders has been found to increase the odds of a GAD diagnosis during the younger years. Brain chemistry. The personality trait neuroticism also appears to be a marker of vulnerability to generalized anxiety disorder diagnosis. Studies have shown that neuroticism predicts both the onset and persistence of GAD. Environmental factors. Childhood adversities such as chronic illness, neglect, physical abuse, sexual abuse, and parental divorce have been shown to increase the odds of GAD onset during childhood or adolescence. With regard to adult onset of GAD, one study found that work stress was one factor affecting a GAD diagnosis, while another study found that one or more stresses preceded the onset of GAD. In summary, current findings suggest that genetic predispositions, personality traits such as neuroticism, and psychosocial stresses interact to produce the full GAD presentation. Assessment. The assessment of GAD presents numerous challenges to the clinician, as the essential features of GAD are present to some degree in normal human functioning. GAD is a disorder associated with high rates of comorbid conditions. GAD symptoms must have been shown to exist separate from other symptoms. For example, GAD needs to have been shown to exist separately from depressive symptoms over the 6-month period, and clear separation from mood disorders and other anxiety disorders needs to be highlighted through appropriate assessment methods. In comorbid cases, GAD tends to be the primary diagnosis when combined with anxiety and mood disorders. Studies of clinical samples have shown earlier onset cases of GAD generally are more severe and are associated with higher rates of comorbidity. Evidence-based psychological practice involves evidence-based assessment. This assessment process incorporates integration of systematically collected data through self-rated and clinician-rated measures, clinical expertise shown through a clinician-administered diagnostic interview, and observance of client preferences to achieve goals and increase the likelihood of positive outcomes. Evidence-based assessment. Once the clinician has established that a patient experienced significant worry and tension, the clinician must decide whether the nature and level of the worry merits a clinical diagnosis of GAD or an alternative diagnosis. An anxiety and related disorders interview schedule for DSM-5, ADIS-5, guides the clinician's line of questioning, followed by a semi-structured clinical interview. Questioning establishes the frequency, duration, and diffusiveness of the worry. Example questions include the following. What sort of things do you worry about? If things are going well at work, do you still worry about it? What percentage of an average day do you feel worried? Do these worries ever intrude when you're trying to focus on other things, e.g. leisure activities? And finally, to establish the duration of the worry to meet the criteria for GAD, the last question would be, over the last 6 months, have you been bothered by worries you've described more days than not? Once the central feature of GAD has been established, the associated symptoms of restlessness, fatigability, difficulty concentrating, irritability, muscle tension, and sleep disturbance need to be the targets of inquiry. This will be followed by questioning that separates GAD from mood disorders, other anxiety disorders, substance abuse disorders, and medical conditions. For example, GAD symptoms must have been present for a 6-month period during which criteria for a mood disorder were not met, in order for an independent diagnosis of GAD to be assigned. Modes of assessment of generalized anxiety disorder, structured and semi-structured interviews. The ADIS-5 has 3 main areas of benefit that allow for evidence-based assessment. One benefit is that many items assist with treatment planning. For example, this interview structure determines if individual's primary problem is excessive worry, and questions probe the specific concerns related to the worry area. Secondly, the ADIS-5 allows for various dimensional ratings that establish the clinical severity rating, the CSR. The CSR can be a useful measure of treatment outcome. Finally, a structured interview like ADIS-5 is a useful tool for differential diagnosis. This interview provides in-depth assessment of other anxiety disorders, mood disorders, somatoform disorders, and substance use disorders. Rating scales. Interview-administered rating scales and self-reported rating scales are important measures to be utilised during evidence-based assessment. The Hamilton Rating Scale for anxiety combined with the Hamilton Rating Scale for depression provide a quantitative measure of anxiety and depression via interview-administered rating scales. Self-report rating scales. The State Trait Anxiety Inventory, the Beck Anxiety Inventory, and the Depression Anxiety Stress Scales are all examples of self-report rating measures that are appropriate evidence-based assessment tools for diagnosis of GAD and any additional comorbid conditions. It is important to note that self-monitoring is crucial to the ongoing assessment of GAD symptoms. It aids in the measurement of symptom patterns, adherence to treatment recommendations, and progress. Treatment. Psychosocial and pharmacological treatments are empirically supported and have proven efficacy for treatment of generalized anxiety disorder. Based on empirical evidence, pharmacological treatments generally should be trialled after psychosocial treatments. Cognitive behavior therapy, or CBT, is the psychological treatment with the most substantial evidence base. A meta-analysis found that attrition rates were lower for CBT than for pharmacology, suggesting that it was better tolerated than medication. Cognitive behavioral therapy is based on a triangular interaction model incorporating thinking, behavior, and emotions. CBT involves self-monitoring, relaxation training to reduce symptoms of tension and arousal, countering anxious thoughts to decrease worry, modification of behaviors that perpetuate anxiety, and relapse prevention. At the core of CBT is what is known as cognitive restructuring. Cognitive restructuring involves the identifying and changing the distorted thinking patterns that produce meta-worry. Meta-worry meaning worry about worry. An example of cognitive restructuring activity would follow this line of questioning. In a cognitive restructuring session, you might ask the client to write down a current worry, then ask the client to write why they worry about this issue. This is followed by asking the client to write down what is the worst thing that could happen. They are then to ask themselves to evaluate if this is likely to happen. This moves on to the question, if it did happen, how would I cope? The next level of questioning delves deeper, asking the client, what do I, perhaps secretly, get out of thinking like this? Note this is particularly useful when trying to establish what perpetuates the worry. Finally, the client is asked to look back at one of the statements they wrote for a current worry, why they worry, or what is the worst thing that could happen, and pretend that a friend said their statement as their answer. Their job is to answer that worry now it is a friend's statement in a compassionate, realistic, and thoughtful way. This form of cognitive restructuring is often successful as the client, the majority of the time, can answer the friend's worry now it is not their own, and then apply it to their own thinking. Anxiety regulation through self-monitoring is also a fundamental part of CBT. A client must be aware of their learned defences to ignore anxiety, which only causes the condition to worsen. An example of this is somebody who writes down their finances over and over to the exact cent to try to control their worry about money. A client must learn how their feelings and emotions affect their thinking and ultimately change their behaviour. In CBT, a client learns the sequence of anxiety so they can regulate their anxiety. The sequence involves a stimulus triggers a feeling triggers anxiety, and then the client uses a defence to warn off the anxiety. Anxiety regulation requires a client to be aware of their anxiety symptoms. Questions such as, how is your thinking, clear or cloudy, alerts the client to pay attention to their physical symptoms and their thinking patterns. The evidence-based psychological interventions in the treatment of mental disorders literature review notes that psychodynamic therapy, mindfulness-based cognitive therapy, and self-help therapy are all evidence-based interventions for generalized anxiety disorder. Despite psychosocial treatments being the preferred starting point of treatment, pharmacological treatments are an effective treatment for GAD. Antidepressants, especially selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs, are often considered the first-line pharmacotherapy for GAD. SSRIs and SNRIs have good efficacy rates for GAD, as well as their added potential benefit of efficacy for depressive symptoms, which commonly co-occur with GAD. Previously, benzodiazepines were the preferred medication, but side effects such as dependence and withdrawal means that they are no longer the first prescribed medication. Outcome measurement. As mentioned in the assessment section of this presentation, ADIS-5 allows for various dimensional ratings that establish the Clinical Severity Rating, CSR. A useful outcome measurement tool for GAD is to evaluate the CSR pre-treatment and post-treatment. Furthermore, looking at the STAI inventory, Beck inventory, and DAS scores pre and post-treatment would also provide a useful outcome measurement. Self-monitoring is crucial for treatment planning, monitoring progress, and outcome evaluation. The Generalized Anxiety Disorder Questionnaire, GAD-7, is an easy-to-use, self-administered client questionnaire used as a screening tool and severity measure for GAD and a useful outcome measurement tool. Monitoring and evaluation throughout is an essential component of evidence-based psychological practice, and the need for follow-up treatment needs to be assessed through outcome measurement tools discussed in this presentation. The Harvard-Brown Anxiety Research Program found 58% chance of clients recovering at some point during their 12-year follow-up. However, nearly half experienced recurrence of symptoms after recovery, and 74% of the 12-year follow-up period clients spent in an illness episode. Recovery was significantly lower for patients with comorbid major depressive disorder, panic disorder with agoraphobia, and substance use disorders. Clients diagnosed with GAD face many challenges, but by utilising all components of evidence-based psychological practice, we are assured to give clients the best chance for recovery.